Okay, well, let's get started. I want to welcome everybody. I'm Brian Perman, President of the Institute for Integrative Health, and it's an honor to host all of you tonight for this important symposium on consequential public health, doing what matters to improve population health. As we're all too aware, despite great advances in medical knowledge and technology, from advanced imaging techniques to trauma care, infectious disease, chronic disease continues to affect 1 in 3 Americans, leads to 70% of US deaths, and accounts for 75% of healthcare costs. We spend as a country twice as much as other modern nations on healthcare, yet the health of Americans are poorer and our lifespans are shorter. The need to better understand and help reverse this crisis motivated me, with my wife Sue, to establish the Institute in 2007, to create a wellness and health model to shift our society's focus from managing disease solely to promoting lifelong health. And maybe in the process, we might be able to increase the amount of money that we spend on preventative care, which is now less than 5% of our healthcare budget. Valuing the power of interdisciplinary collaboration and research, we here at the Institute for Integrative Health pursue bold ideas that challenge the status quo and use cutting-edge science to understand the dynamic processes that affect our well-being. These insights then inform us to develop practical, evidence-based programs for individuals and for communities. So tonight, we'll be hearing from 3 inspiring leaders, each who is known for doing what matters to cultivate health and well-being for all. After the presentations, we'll have time for questions and discussion. Our evening begins with a special presentation by Dr. Sandro Galea, world-renowned physician, epidemiologist, author, dean, and Robert A. Knox Professor at Boston University School of Public Health. Previously, he held academic and leadership positions at Columbia University, University of Michigan, and the New York Academy of Medicine. Sandro has published more than 800 scientific journal articles, 50 chapters, 13 books, and his research has been featured extensively in current periodicals and newspapers. And if you consider the fact that the currency of academia is publications, Dr. Galea has made a lot of dough. His latest book, to come out soon, Well is the title of it, What We Need to Talk About When We Talk About Health, will be published in May of 2019. Arianna Huffington has called it a deeply affecting work from one of the most important and innovative voices in American health and medicine. Time magazine named him an epidemiology innovator, and he's been listed as one of the world's most influential scientific minds. Sandro has also received several Lifetime Achievement Awards, including the Remy Lapousse Award from the American Public Health Associations and the Robert S. Laufer Memorial Award from the International Society for Traumatic Stress Studies. The Institute is honored to know him as a colleague and collaborator of Dr. George Kaplan, one of our Institute scholars, who together co-authored the book Growing Inequality. And in George's words, what truly distinguished Sandro, in addition to his awesome academic productivity and awards, is failure. A failure to take the safe path of incrementally advancing public health and that which can be easily studied. He does not shy away from the most wicked problems of public health that reach to the very core of society. And after reading a preprint of his upcoming book, I was struck by how aligned his work is with the mission of our Institute. We share a vision of health and well-being as an integration of how and where we live, work, and play. Now more than ever, we need new action to catalyze, in the words of Jonas Salk, an epidemic of health. So please welcome Dr. Sandro Galea.
All right, excellent. Now we can get going. So the event is built as being about consequential epidemiology, which is, I think, which is a term which I've put out in literature that really says that we should be thinking about what ultimately matters, that we should be doing science and we should be thinking about what ultimately matters. And that's been a bit of a winding journey for me over the past 5 years that has brought me to the subject of this book. And the subject of this book really is ultimately what is it at heart that should matter to all of us who care about health. And I'm going to make the argument over the next sort of 35 minutes that what we think about health is wrong and we should care about different things. So having said that, I'm going to plunge in. I'm going to start with this point. We care about health. In divided times, health is one universal value. It doesn't matter if you're red, you're blue, you're purple, we care about health. And survey after survey show us that that's the case. I'm going to show you just one survey. And this is just one survey from a couple of years ago. Top issues for Americans, and you see health net first, and unemployment, terrorism, et cetera, et cetera. So we know we care about health. And I can show you countless polls about this. Now, whenever you have somebody like myself coming to speak, you heard my bio, you always expect that I'm going to say bad things, which is fine. It's a hazard of the job. So I'm going to start with good things. I want to show you a couple of slides on good things. This is the best time to be alive if you care about health. And I'll show you sort of data on this. This is life expectancy worldwide. The longest series of life expectancy is the UK. What you see is that people all the way, like for hundreds and hundreds of years, life expectancy until about the mid-19th century was roughly 40 to 45, right? And then in the past 150 years, we've jumped to about 80. Now, I'm often speaking to audiences like this, which is well-educated audiences, and I often ask the audience, how would you have made life decisions differently if you expected to die at age 40? Most people will say, I would have gone to school less. That's typically the first answer I get. And, but I just want to point out that that is the case for like the entire human history, right? 150 years is a blink of an eye. And it's only been these 150 years that actually our life expectancy has gone up like that. And it's an extraordinary rise, never before seen. And at the same time, we have done much better on things like this. This is global child mortality, and the red line shows the percent of children who die before the age of 5. As recently as 150 years ago, almost 1 in 2 children died before the age of 5, and now that number has become negligible. So this is a good time to be alive if you care about health. Now, I'm going to move to the not so good, and I'll give you a framing that my comments are US-based. I could do this kind of talk as global, but this is a US-based talk, and I'm happy to talk global afterwards. So let's talk about what's not so good. So first of all, I could take any number of health indicators, and here I have non-communicable disease, which means cancer and heart disease. And what you have on the y-axis is mortality. And what you see is the US is the red bar, and on the left of it are all the other high-income countries. Now, whenever we have elections, there's always this whole bunch of stuff about, well, we're not Denmark and we're not Sweden. So yes, we kill more people than Denmark and Sweden, but we also kill more people than Greece and Italy, and they can't get anything right, but they still kill fewer people than we do. So and I could show you this for any number of diseases, that we have worse mortality than anybody else. So that's point A. Point B is we are extraordinarily consistent in our capacity to do worse than anybody else. So this is now by age. This is by age, and all I want you to see is on the x-axis is age. So you start from newborns, infants, adolescents, etc. And you see two things. Number one, you see this U-shaped curve. This is mortality again. That's typical, because the healthiest years of life are the older childhood and early adulthood, right? So that's less mortality. But look at the two bars, the blue bar and the red bar. The blue bar is the United States. The red bar is all the other high-income countries. So what I want you to see is that the blue bar is higher than the red bar at every age group. So we kill more newborns and infants and children, and adolescents and young adults and middle-aged adults and older adults than any of our other peer countries. Now, most educated audiences sort of know this. You sort of know that our health is not as good as it can be. But we sort of also accept this with a bit of a shrug. It's like, well, we're just not so good at health. And we sort of accept that. Like, you know, it's like saying, like, you know, we're not so good at cricket. But we forget that it wasn't always thus. And in fact, it wasn't thus not very long ago. So this is from really one of the best Institute of Medicine reports that's ever been put out, which looks at life expectancy. This life expectancy, the red dot is US life expectancy. The gray dots are other high-income countries. This is just going back 35 years, not very far. All I want you to see is that 1980, we were in the top half of countries. And look what's happened over the past 35 years. We have drifted to the very bottom. So we have created the kind of country where we have allowed ourselves to have our health become worse than all the other high-income countries. Now, I say this intentionally, we have allowed ourselves, because this is not magic. Like there are no supernatural forces that are making our health worse. This is the result of decisions that we are making that is making our health worse. And as we've been doing that, other countries have gotten better than us. And not just countries like Japan, but also countries like Singapore, countries like Chile, and countries like Costa Rica. These countries have surpassed us in life expectancy. So the picture is this, that we have health that is worse than all other peer countries. I'm not comparing us to Zambia. It's not fair to compare ourselves to Zambia. I'm comparing us to high-income countries. We have health that's worse. Now you can say, okay, well, you said we care about health, but maybe we don't care that much. Maybe we don't put enough money into it. Is that true? Well, we could put a lot of money into it, but this is what we're getting out of it. This is, by the way, I like the slide very much. This is from Washington Post. This is American exceptionalism. It says our health was getting better than everybody else until about the late 80s, and then we became worse than everybody else starting in the late 80s, early 90s. And here's the money we're putting into it. We are the green line in terms of money. The other rational countries in the world are the gray line, and the average is the blue line. So you see, we spend about 40% more per person than the next closest country. And we have the rate of change of spending is more, and the rate of change is also more. So we throw a lot of money at this issue. And the challenge I would make to an audience like this is this. Think of one other sector where we far outspend everybody else and have worse outcomes than everybody else. It's actually impossible to think of another sector. It's impossible to think of another sector where we would tolerate this. Like, why would we tolerate this? I mean, we spent more than everybody else on our iPhones, but have worse iPhones. Like, we just wouldn't accept that. But for some reason, we accept it on health. Like, this is just the reality, and we accept it on health. Of course, there are many things I could even tell you that are more than this, that we now have the worst downturn in life expectancy that we've ever had since the 1918 flu pandemic. But again, we accept these things on health. And if I were to show you just one graph that makes this case most clearly, it's this one. And the way to read this is, on the x-axis you have spending, on the y-axis you have life expectancy. Along with you see all those gray lines, they go up together. You spend more, you get more life out of it. But look at us. We're like off the chart. Now for any of you who ever had children and you go to the pediatrician and the pediatrician does a growth chart on children, if they ever did that, you'd call those children failure to thrive. We are failing to thrive on health. Now, that's the bad stuff. Now I've called this in the past something called an unhealthy mismatch. There's a mismatch. What's the mismatch? The mismatch is what we achieve on health and how much we care about health. So what we care about health a lot, but we achieve very little. And the question is why? Why is there that mismatch? And I think that mismatch is due to two reasons. I think half the blame should go with those of us who are in the science, who actually produce the science on this. And half the blame is on the national health conversation. I'm not going to talk about the science today, but I want to label it because I think it's actually part of it. But I want to talk about the national health conversation. I want to talk about what is it that we talk that's not right about health, and how is it that we can change the conversation on health to fix this. Now let me go back to the slide I started with. This is the slide I started with about people caring about health. The slides that I showed you before only showed you the brown bar. You see health was number one. Here I've overlaid on it what actually media talks about. And in this case, you can see the mismatch between what is talked about in media, what people care about. But that's fine. I mean, that's a little bit of a cheap shot at the media. But actually, what I really want you to look at, while you're all chuckling at my cheap shot at the media, is that I've said 3 times since I started that this slide shows that Americans care about health. And I'm going to challenge you to say, how many of you in your mind stopped and said, that's not what the slide shows at all? The slide doesn't show that. The slide shows that Americans care about healthcare, not about health. Now, for those of you who actually corrected me in their head, kudos. I've done this before. Most of you did not correct me in your head. Why is that? It is because we are so accustomed with this conflation of health and healthcare, which is part of the problem and sets up the problem that I want to talk about. So, I want to talk about what it is that we should be talking about when we talk about health. And for those of you who are sort of postprandial, sort of feeling a little bit sleepy, I'm going to sort of do this in 10 points. I'm going to go through 10 points very quickly about what it is that we should talk about when we talk about health. Number one. Number one builds exactly on what I just said, is that we should be talking about health and not about healthcare. And to make that point, I'm going to start with a story. Anybody know who this is? What's that? This is Blind Willie Johnson. I don't know if that's what somebody said. Yeah, Blind Willie Johnson, bluesman. Blind Willie Johnson was a bluesman. We remember him because we remember a bunch of his blues songs. He was born in Texas at the turn of the 20th century. He was born sighted, actually, and at age 7, his mother threw a lye in his face in a domestic violence incident, and he became blind. So he grew up poor, blind, black, Texas, turn of the 20th century, learned how to play the guitar, made a living busking, not a very good living, as you can imagine. Got married, was living in a small hut burned down, but him and his wife didn't have any money, so they kept living in a burned house. Turned 40, and Blind Willie Johnson got malaria, which was not uncommon at all in Texas at that time. This is now we're dealing with the 1940s. His wife took him to hospital, and he was turned away from hospital. It's not clear if he was turned away because he was poor, blind, or black, and then he died. So the question is simple. What killed Blind Willie Johnson? Well, what killed Blind Willie Johnson is malaria, right? Had he taken chloroquine or mefloquine, he wouldn't have died from malaria. But when I tell you a story like that, which is obviously an extreme story, I'm doing it on purpose, it's hard to avoid the fact that if malaria didn't kill him that day, something else was going to kill him the next day. Because it wasn't just malaria that killed Blind Willie Johnson, right? It was racism, it was poverty, it was access to care, it was domestic violence, it was homelessness. Those factors also killed Blind Willie Johnson. And that's the difference between health and healthcare. Healthcare is treating the malaria. Health is everything else. Now, I want to be very clear that this is not an either-or. Malaria is a disease, it results in pathophysiologic breakdown, which can kill you. So we actually do need healthcare, and we do need medicine to treat malaria. But doing that by itself is never going to be enough. And hopefully through that simple story, one can tell why it is that there is this mismatch. Because I said we spend so much money on health, but we don't really spend it on health. We're spending all our money on treating malaria, and we're ignoring everything else that ultimately contributes to health. Now, I started with a story, but let's sort of move into something a little bit more robust. So this is the spending mismatch. The bar on the left is, broadly speaking, what sort of most people circle around as to what causes health. Genetics, about 20%, medicine, 5 to 10%, our physical environments, our social environments, about 25%, our behaviors, another 30, 40%. That's the bar on the left. The bar on the right is what we spend our money on. We spend our money all on the green, which is all medicine and access to care. That's the mismatch between health and healthcare. We spend all our money on healthcare rather than spending it on health. And when I say we spend it on health, on healthcare rather than health, we actually don't spend anywhere near as much as many other countries on the forces that generate health. And the way to read this is, these are what's called here social services, although it's a very general term, showing that actually on the left is our health consumption, which is healthcare spending. On the right is our spending on other stuff. On the other stuff, we're roughly in the middle with other countries. And when you put the two together, if you recognize that spending on these forces together is what generates health, we actually are not overspending on health at all. We're overspending on healthcare, putting all our money in malaria. We're not overspending on health. And I live in Massachusetts, which is a state which is has a very proud tradition of being fiercely progressive. And sometimes I give a talk like this in Massachusetts. People say, well, yes, that must be another state like Maryland, not in Massachusetts, which is actually, I don't know what it's like here, but I'm sure it's better than Massachusetts. This is spending in Massachusetts. We have, in the past 15 years, increased our spending on healthcare by 80% and decreased or kept the same our spending on primary, secondary education, law and public safety, mental health, public health, higher education, early childhood education, environment, and recreation. That's in what arguably is the most progressive state in the Union. Right? So that is the picture that we're in right now. So point one, health, not healthcare. Point two, health emerges over a life lived. We see health as a point in time. We tend to think of health as the 42-year-old man who is 30 pounds overweight, who comes to the doctor's office, and his knees have arthritis, and he's going to need a knee replacement. The entire conversation about health in our public is, well, knee replacements cost a lot of money. Does he need a knee replacement or not? But that's not the conversation. The conversation should be, why does he? Why is the 42-year-old in your office with arthritis needing a knee replacement when he does? So in order to make this case, I just want to show you a cartoon, actually. And I'm going to step here so I can read it, because I can't read it otherwise from where you are. So I'm going to show you this cartoon. And this cartoon has two panels. If you just follow the panel on the left, the panel on the right, very briefly. On the left, you have Richard. His parents are doing okay. On the right, you have Paula. Her parents, not so much. Richard's house is warm, dry, shelves are full of books, fridge full of food. Paula's house, full of people and not much else, damp and noisy, she keeps getting sick. On the left, Richard's parents will do anything for their baby. Good boy, clever. And so will Paula's parents. That's why they're working two jobs. Richard goes to a great school, well-resourced, good job, good kids, his teachers love their job. Paula's school, class sizes are large, the class school is underfunded. So maybe we can see why the expectations of Richard, B plus, oh dear, we need to get you a tutor, might be slightly different, those set for Paula. B, hey, that's not bad. Over the year, these little differences add up. Parents paying for university, struggling work and politics, getting in debt. They start to add up and build in something bigger. On the left, I have friends working there. I'll have a word and get you an internship. Thanks, Dad. Her dad said, you should be finished your studies, not looking after me, but Dad, you're sick. And because each little difference sneaks by unnoticed, yep, the loan is approved, congratulations. Look, we can't help you, maybe try easy finance. Then maybe Richard starts to believe that he deserves to be on top and he did it by himself. It says, you're Roger's boy, right? I heard good things, keeping my eye out on you. And Paula starts to settle, learns to know her place. Okay, you've got the job, but I'm watching you, sweetie. And we're at a party. There's this, congratulations, Richard. What's the secret to your success? Paula's on the right says, excuse me. And Richard says, less whinging, more hard work, I say. I'm sick of people asking for handouts. No one ever handed me anything on a plate. Now, it is entirely true that Richard worked very hard. There's no question about it. It is also equally true that he's worked hard on a ladder of a million small advantages. And health is generated by those advantages or those disadvantages. The difference between Richard at 42 and Paul at 42, well, he's playing tennis and being totally fit, while she's actually overweight and having arthritis in her knees, is this little sum of these advantages and disadvantages. And we forget that all the time. And what we need to talk about when we talk about health is the cumulative effect of life course that ultimately generates health. Now, I'm showing you a cartoon, but I can show you this with data as well. So let me just show you one simple slide. This slide, all I want you to see here is, this is what we call a dose-response relationship, right? X-axis goes up, the Y-axis go up. This is the number of traumas experienced in childhood and your likelihood of using cocaine as a teenager. More trauma, more likely you are to use cocaine. Now, I'm using cocaine intentionally because what other behavior is there that we stigmatize more, that we point fingers at and says, well, he should not have used that drug. She should not have used that drug. Right? We say this over and over again. Our tolerance for this is vanishingly low. And then you look at something like this. Well, did she or he deserve the trauma that they experienced? Right? How much do we think of that when we say, thou shalt not use cocaine, thou shalt not use the drug? But ultimately, our life experiences are all patterned on previous experiences. And when we talk about health, we should talk about the cumulative effect of those life experiences, which means that if we want to change the conversation, we cannot forget that. And if we want to improve the health, we cannot forget this cumulative effect over life course. Point 2. Point 3. Power, politics, and money are health. Now, I'm not saying that power, politics, and money lead to health. I'm actually saying that they are health, that these are inextricable from health. And to make this point, I'll go back. I'll go back to 1863, Civil War, and the Conscription Act. Conscription Act 1863, which resulted in the famous 6 Points riots, because it was essentially the act for union for soldiers to be conscripted in the army. But the riots were not about the conscription. The riots were about the fact that obviously being a soldier in the Civil War at the time was a high mortality endeavor for young men. The riots were about the fact that even then, a little bit of money, or a lot of money, depending on your perspective, could get you out of this high-risk endeavor. $200 could buy you out of joining the Union Army. And the riots were about the unfairness of that money, in a very naked way, very transactional way, was buying you better health. Now you're saying, that was 1863. It's the bad old days. Well, is it such bad old days? There's Arlington National Cemetery, where we bury our war dead, and here and many other cemeteries around the country. Why am I showing you this? I'm showing you this because if you take all our dead in uniform from all wars since the Second World War, that number is still lower number than the number of people who've died from handguns in the United States since the Second World War. So we've killed more people by guns domestically than we have in all our armed combat. Now, why is this related to power, money, and politics? Because there is no way around it that our continued indulgence of a firearm epidemic in this country is inextricable from power, money, and politics. I'll show you one graph on this. This is our loss of life due to firearms compared to other countries. You can see the extraordinary disparity we have between us and other countries. And this is why that's the case. So the way to read this is, over time, there are two bars that matter, the purple bar and the orange bar. The purple bar is spending on gun rights lobbying. The orange bar is spending on gun control lobbying. What I want you to see is that the purple bar always dwarfs the orange bar, but look at Sandy Hook. Sandy Hook happens 2012. You see how much gun rights lobbying, gun control lobbying goes up, but look at gun rights lobbying, right? So this ultimately is what drives the fact that we have more deaths from domestic handguns than we have from all armed conflicts combined since the Second World War. This is why health is inextricable from power, money, and politics. And I can show you other things that are less controversial. I'm showing you guns on purpose to wake you up a little bit, but you can argue with me afterwards. It's fine. This is something much simpler. This is state subsidies for corn. Corn, which leads to high fructose, calorie-dense, nutrient-poor foods. More state subsidies for corn, more obesity. Dose-response relationship. And I can show you this over and over and over again. Ultimately, our health is inseparable from our politics. Third point. Fourth point. We cannot have health for the many if we exclude the few. Now, we're a charitable country, and we like helping the poor. Now, I'm using these words very intentionally, because I actually think it's a phrase that should never be uttered, because it ultimately marginalizes and puts people in a corner that distances it from us. But this is part of our conversation. We are in it to help the poor, and the rich give to help the poor all the time. That has a distancing effect, and that effect ultimately says that, look, I hear you about these statistics you're telling me, but, I'm okay. I'm okay, and I'll do my bit to help the poor, and it's going to be okay. Well, that thinking is actually wrong. Leaving aside the moral argument, just leaving aside the moral argument, there's ample epidemiologic data that suggests that we cannot have health for the many if we exclude the few. And, the argument about health for the many excluding the few comes ultimately from utilitarian arguments. This is Jeremy Bentham, the father of utilitarianism. This is Jeremy Bentham. He's mummified outside University College London. If any of you will go there, you can see him. It's actually him, although not his face. His face was eaten by bugs, and it's wax, but the rest of him is him. So this actually is Jeremy Bentham. And utilitarianism is ultimately says that we should be in the business of maximizing health. We should be maximizing the health for the many, if we at all can. But utilitarianism forgets this, that says, we don't care about health systems in West Africa. I mean, who cares about health systems in Liberia? Who can even point a finger at Liberia on the map? Until this happens. Until Ebola in New York City happens, which is a direct result of breakdown of health systems in West Africa. The health of the few, be those few in Liberia, far away from us, have a direct impact on our health here today. Here's another example. The anti-vaccine movement. This is a group in Minnesota where anti-vaccine movement targeted Somali immigrants, resulting in a measles outbreak, not just in the immigrant community, but in the entire community around. Vaccines ultimately remove infectious disease reservoirs, and the health of the few influences the health of the many. And how about this? 10% of kids who are killed in car accidents in this country are pedestrians killed by an alcohol-impaired driver. They have nothing at all to do with the driver. Right? And I could go on and on. Our health is intertwined. Unless you're going to make an argument that you can wrap yourself in bubble wrap and protect yourself so that nothing affects you, you have no choice but to recognize that your health, even the health of all of us in the room, sitting in this room with extraordinary privilege, depends on the health of everybody. That's the fourth point. Fifth point. We need wisdom and humility to understand health. So what do I mean by that? Our lens of understanding health influences how health is shaped and how we think about health. And I'll start with this. This is the production. This is why how health is produced in the body. It is a balance of blood and phlegm and yellow bile and green bile. That's how health is shaped in the body. And when you have fever, it's because you have too much blood. So the treatment for that is we let out some of your blood. Now, you're all sitting there and snickering, but that, by the way, was accepted as the root pathophysiology for 2,000 years. All our newfangled understanding of physiology, it's a couple of 100 years old. That was we believed for 2,000 years. So there's nothing really crazy about it. I mean, the majority of the sentient human species believed this was the case, and this is why we let blood. Now, why am I telling you this? I'm telling you this because we have similar orientations and biases. There are similar lenses that we accept and adopt without thinking about how they distort our actions and how they distort what we do. So, this is the CDC website. Just do a search, leading causes of death. Leading causes of death are number 1, heart disease, number 2, cancer, etc. That's what the CDC website says. There's nothing wrong with that. That's true. About 20 years ago, CDC did a paper which said, well, let's take this a step further. Let's not focus on heart disease and cancer. Let's focus on the behaviors that kill us. And they came up with this list, that leading causes of death are tobacco, poor diet, alcohol consumption, counting the causes of death. And then, 10 years ago, we did a similar paper that said, let's take it a step further and say, what about low education and poverty and low social support and segregation? How many people do those kill? And just to put these side by side for a second, the number of people who die from low education in this country is the same as the number of people who die from heart attacks in this country. The number of people who die from low social support or social isolation is the same as die from stroke. Now, so what's the leading cause of death? Is it heart disease? Is it tobacco smoking? Or is it low education? Well, the answer is all three. Yes, the answer is yes, right? But does it matter? Of course it matters. Because if you say the leading cause of death is heart disease, you know what you're going to do? You're going to create a National Institute of Heart and Lung and Blood. If you say the leading cause of death is tobacco smoke, you're going to create a National Institute of Tobacco. If you say the leading cause of death is low education, you're going to create a National Institute of Low Education. So our lens on the world really matters. It influences our perspective, and it influences where we put our resources. And our resources ultimately shape what we do, shapes our science, and shapes our conversation. So we need to have the humility to recognize that our lens on what produces health really matters, and it influences how we think all the time. It did when we were bloodletting, and it does today. This is my sort of favorite example of this. This is these two gentlemen with luxurious mustaches. Gentleman on the left is Edwin Chadwick, gentleman on the right, William Farr, two of the founding fathers of what today we call public health. Edwin Chadwick was a politician. He was responsible for the British Health Act of 1848, one of the most important consequential acts to clean up cities. They had an argument. William Farr was counting statistics, and he said poverty was killing children in London because he did the tables and found that poor children were dying of starvation. So he said, poverty, starvation, killing children. There's a great quote for Edwin Chadwick where he says, children do not starve to death in civilized London. So what was Chadwick's explanation for why the kids were dying? Micronutrient deficiency. Now, is that true? Well, of course it's true. Is it also true they were starving? Of course it's true. Is it true they're starving because they're poor? Of course it's true. But why does it matter? Well, it matters because if you say the reason for that is micronutrient deficiency, you just need to invest all your money in drugs so you can give them some micronutrients. And that is what we do today. So the point is, we need to have the humility to understand that our actions are frequently driven by a very particular lens, and that lens determines what we do and why we do it. Point 6. I buried this point right in the middle because this is perhaps the most controversial point, that our health should be understood as a public good. If you believe the previous points I made, you inevitably come to this conclusion. So to dispute this, you have to sort of dispute the previous point. That you actually cannot have health for all without recognizing that health is a public good. Now, what's a public good? There's a textbook definition from Affluent Society, which is things that do not lend themselves to market production, purchase, or sale. They must be provided for everyone if they are to provide for anyone. And they must be paid for collectively, or they cannot be had at all. That definition is the direct opposite of how we treat health in this country. But if you understand that you cannot have health for the many without having health for the few, if you understand that our health is intertwined, that power, money, and politics play into health, you inevitably come to this. Now, the typical response I get to this from educated audiences is, it's a pipe dream, you're dreaming. Okay, perhaps. But there are other things that we treat as public goods that actually are absurd that we have the courage to treat them as public goods. What's an example? Look at this extraordinary piece of real estate in the middle of Manhattan, which we actually dedicate to be a park. We call it Central Park. Now, you're saying, well, what's the alternative? Well, of course there's an alternative. We don't have to treat it as a public good. I lived in New York for 10 years, and when I was in New York, I didn't want any of you tromping over my piece of the park. What we should have done is divide up the park, and I could have had my parcel of the park. Now, you're all laughing. You're all saying, well, that's absurd. But it's actually not absurd at all. That's exactly what we do with health. And it is our failure of imagination that we do not treat health the same way we treat public parks. And if we have the boldness of vision to think of parks this way, why can't we have the boldness of vision to think of health this way? This is what happens when we don't. Things like Flint. Flint was a classic example of how we stopped thinking of health as a public good. It became not my problem, became somebody else's problem, resulting in poisoning of people in a town for years and years and years. 7, we need to think of compassion at the heart of health. Now, what do I mean by compassion? I'm going to go to Martin Luther King on this, who is probably Boston University's most famous alum, where he says, true compassion is more than flinging a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring. That's what compassion is. That's how compassion is different than charity. Compassion says, we're not just giving money to the beggar, we're saying, why is she a beggar to begin with? Now, how does that manifest? How does that manifest in how we should think about when we think about health? Well, here's how it shouldn't manifest. If I go back to guns for a second, these are tweets from several senators sending thoughts and prayers with family and friends of victims. And I only pick tweets from senators who are on the record as having done absolutely nothing and, in fact, actively opposing doing anything about guns. That is the opposite of compassion. Let me tell you one story that shows how deep a lack of compassion can run. This is a heartbreaking story, and I'm going to go back to Liberia because I talked about Ebola. I'm trying to sort of weave some themes through. This is from Salome Karwa. She was one of Times Persons of the Year in 2014 when we had when there was the Ebola outbreak. Salome was a nurse, and she contracted Ebola, and she lived. She contracted Ebola, lived. About half the people who contracted Ebola live. And then she had the extraordinary strength of character to say, I want to volunteer to go work with Ebola patients after she had already had Ebola herself, which is extraordinary. I ask you, how many of us in this room would have Ebola, survive Ebola, and then say, I want to go work with Ebola patients? I know I wouldn't. So she goes works with Ebola patients with Médecins Sans Frontières, which is why she made it on the cover of Time Magazine Person of the Year. After the Ebola was over, she was pregnant with her 4th child, and she had obstructed labor. Her husband took her to the hospital in Liberia. The main hospital in Liberia is called JFK Hospital, where I did some work. And she was turned away from the hospital. You know why she was turned away? Because she had had Ebola. Then she died. Now, I'm using Liberia intentionally, and I hope you actually work with me. I'm actually using Liberia not to say this is a problem there. I'm using that to give us a lens on ourselves. We do this all the time here. Right? We do this all the time. We allow the structures that perpetuate poor health to exist. What are examples of those structures? Well, here's an example. Segregation is one of those structures. Segregation is the racial segregation is the direct result of policies that allow segregation to happen. And that is mapped on, this is Chicago, by the way, mapped onto lower life expectancy. And I could spend a whole hour showing you how segregation is ultimately linked to poor health through violence and through a whole set of other mechanisms. This is how we allow the structures that generate poor health to exist. Point 8. Health should be a means, not an end. Now, that might seem like a funny thing for somebody who's in the business of health to say, but I think this is actually critical. Because I ask you this question. How many of you actually enjoy taking your car in to the mechanic? Nobody does. Right? You just want your car to work. Health should be like that. We should all be able to get on with our lives and do what we want and live in a world that generates health around us and not worry about it, not think about it. And of course, that is a mind shift away from health being an end, which means if health is an end, that we are living just to create health or living to try to live forever. That means we should stay away from this. This is a time cover, and this baby could be 142 years old. The answer to this cover is no. This baby is not going to be 142 years old. I don't know who that baby is. Adorable though they are. But they're not, because actually the science is actually pretty clear, despite our efforts around things like personalized medicine, precision medicine, that are trying to find the silver bullet and the cure for everything, that actually this is from a paper just came out in Nature last year. We probably have a natural limit of human life expectancy of about 115. And while we can gain years towards that, at the end of the day, we're a complex system that will break down and will die. And that should be okay. We should be focusing on actually generating health so we can live well, do our thing, whatever our thing is, and then die well. So we actually ultimately want to die healthy. So enough of the focus on living forever. By the way, just so to give you some metrics, 98% of Americans die before the age of 100. There's no baby's going to go to 142, just as simple as that. And that changes our mindset and says, let's should focus our money on living well so we can all die healthy. This is a memento mori, which is a tradition maybe should come back, which was burying the dead with something that reminds them of what they actually did that made it worth living. And it's certainly not worth living if all we're doing is just aiming to just live so we can be healthy. So point 8, health should be a means, not an end. Point 9, we need to value health and we need to demand health. And this is true, it's Senator Mikulski will comment about this much better than I can. I think of our elected officials over and above everybody else, that elected officials can only do so much unless we, the people, actually demand health. And just to use one example, this is two gentlemen. The one on the left is Remember, the one on the right is Not. On the left is obviously LBJ. The one on the right is Wilbur Mills. Wilbur Mills was the chair of the House Ways and Means Committee. He was also one of the primary opponents to Medicaid when it was coming in, until, of course, LBJ swept the election, and instantly Wilbur Mills changed his mind because there was an enormous popularity of these Great Society programs at the time, and Wilbur Mills became a proponent. This is an example of the people demanding health and demanding something that should lead to health. And this is why I think in science, those of us who are in the business of science, we really cannot just sit back and expect that data should just speak for itself. That ultimately, we need to understand that what is going to influence, what's going to result in consequence towards positive health, is a balance of the data and values. And this is sort of a very simple 2x2 table. I'm putting four issues here, and what you have on the bottom is evidence. On the right, we have evidence. On the left, we don't have evidence. Top row, public opinion says we should do something about it. Bottom row says public opinion says, not so sure. So top right, polio. We know what to do. Nobody wants to get polio. That's easy. Top left, Zika we don't really understand, even though the public doesn't want it. Bottom right, we know what to do to reduce the harms of injection drug use. We know that safe injection facilities make a big difference. But public opinion, very NIMBY, very not in my backyard about safe injection facilities. And then you have bottom left, where the evidence is nowhere near enough, and public opinion is very mixed. Ultimately, data must be balanced, has to be balanced with what we demand if we're going to see action. Here's another example, prevention. How many of you would rather live in a world where you have treatment for your Alzheimer's disease versus a world where you never get Alzheimer's to begin with? I've yet to find anybody say, no, me, I want to get Alzheimer's and then get treated. No. But this is our spending. Our spending on prevention is abysmal. We are not demanding prevention enough. Let me give you one other concrete example. We have in this country had 70,000 excess deaths from breast cancer, mostly in women, all since this great reversal in our health fortunes in the late 80s. We used to be better than all other countries until then. And now we have more and more people dying from this because we're not demanding health, we're not demanding prevention. And last point, 10th point, we should be free to choose health. So I leave this for the end because at this point, somebody in the audience is getting irritated with me. And somebody's saying, so maybe it's more than one person, but the irritation typically is like this. The irritation is typically, well, yes, you're saying all these things, but you just don't understand America. Sometimes in unkind audiences say, you have an accent, sounds like you might not be American. So you don't understand, Americans like freedom. We like our freedom, and we want our freedom to do what we want. So I just want to tackle freedom for a second. And I would like to argue that one of the core pieces of what we should talk about when we talk about health is indeed freedom. But we have a misunderstanding of freedom. So freedom comes from the founding ethos of this country. And the founding ethos of this country is about freedom, yes. But it's not just about freedom too. It's not about freedom only to do what you want. It's also freedom from It's freedom from things that stop you from doing what you want. And it has been a successful narrative takeover in this country that it's all about freedom to, which is hogwash. Freedom to and freedom from should be balanced. Now, what do I mean by freedom from? There's an obesity map in this country. And this country is very obese. It's like, it's bad. You know, when you talk about obesity, you have arguments like this. This was about in New York City when Mayor Bloomberg was introducing, trying to reduce large-size soda for containers, and you get, you know, the media, which is a long story behind this, made this seem like a sort of a nanny state argument. But really, is it really? If we're trying to give people freedom from being obese, because ultimately, what's obesity driven by? It's ultimately driven by a world around you that makes you obese without you even noticing it. And if you don't believe me, look at this. A bagel 20 years ago had 140 calories. Today, a bagel has 350 calories. So good luck to you if you had a bagel this morning. Actually, good luck to you if you had a muffin this morning. Muffins used to have 200 calories. Now they have 500 calories. And of course, this crowd is too healthy to eat cheeseburgers. But if you did, you know, God help you. This is what takes away our freedom from obesity. And I would like to argue that part of the conversation on health should be balancing freedoms from and freedom to, and making sure that we elevate our freedom from unnecessary disease. And we've done this before. I mean, we know how to do this. This is one example. This is the enormous triumph of reducing deaths from motor vehicles. The blue line is deaths from motor vehicles going down. The green line is how much miles we're driving. We die about 20 times less in cars, despite the fact we drive 20 times more. Now, how do we achieve that? We have achieved freedom from dying in cars. Did we achieve that by letting people do what they want? Did we achieve that by making better drivers? No. No, we achieved it through seatbelts and airbags and shatterproof glass and laws against drunk driving and all the things that you all know about. Because people are crappy drivers now the same way they were 100 years ago. And they are going to remain so. And we chose freedom from being run over by a car as much as humanly possible. We chose that, and we can choose that. We can choose much more of that if we want to. So I want to conclude. This is my last slide. I want to conclude with a slide about the only sport that really matters. The only sport that really matters is football. And by that I mean real football played with feet. Let me ask you this question. What's the best American football team? What's that? The women's Olympic team is indeed the best American football team. Absolutely. This is the team that won the gold medal in the last Olympics. They've now changed over. Now, for those of you who don't understand football, let me explain how the sport works. 11 players on each team. They can only use their feet. Hence it's called football. Except for one person, the goalie. The goalie is the woman in red. The goalie can use all parts of her body. So, if you've never played football, you say to yourself, aha. If you have the world's best goalie, and Hope Solo, who was the goalie here, was very good, you'll always win. Because she can do anything she wants to keep the ball out of her net, right? But if you watch a professional soccer game, here's what you see. You see the goalie prowling her area, yelling at the other players. Now, what's she yelling at them? What she's yelling at them is, keep the ball away from me. Because the best goalies know that the net is pretty gosh darn big, and it doesn't matter how good she is, a ball's going to come and she's going to lose the ball. Now, why am I telling you this? The goalie is medicine and healthcare and treating malaria. You want a good goalie. We want a good goalie, and we should want the best goalie in the world. But the goalie by herself is not going to generate health. We need to align our power and our politics. We need to align our values. We need to demand health. We need to have compassion for health. We need to generate health every step of the life course. Those are the other 10 players. Those were the 10 points I covered today. Because without those, we are never going to undo this mismatch. And we're never going to improve health the way we actually want to improve it. And that, I think, ultimately is what gets us to a health conversation of consequence that can really generate health. This is the book that this is roughly about. Thank you very much for having me. It's really a privilege of being here.
Beautiful. Thank you, Sandro, for a really inspiring talk. And thank you for pointing out how important it is to embrace health as a collective value and how we need to value it enough to put it front and center and put the investment into it to really make a difference. So our next speaker, I've had the pleasure of knowing Jay Perman for more than 20 years. I was delighted when he became the 6th president of the University of Maryland, Baltimore in July of 2010, where we worked together during my time leading the university's Center for Integrative Medicine. He was named one of the Maryland's most admired CEOs in 2013 by the Daily Record. And Jay Perman is focused on creating a dynamic, and I would say holistic, university culture. A pediatric gastroenterologist, he continues to practice medicine through his weekly President's Clinic, where he teaches team-based healthcare to students of medicine, nursing, pharmacy, dentistry, law, and social work. Furthermore, he's strengthening UMB's role in improving the health and well-being of its closest neighbors. In the fall of 2015, he opened the UMB's Community Engagement Center in West Baltimore to provide direct health, employment, legal, financial, and social services to nearby residents in West Baltimore and to engage with them in neighborhood strengthening advocacy projects. He also established a fund for revitalization projects undertaken by the Southwest Baltimore community. He has started a UMB Cure Scholars Program, which is an intensive long-term mentoring program for West Baltimore middle school students intended to excite them about science and ultimately prepare them for rewarding careers in research and healthcare. I could really go on, and I can see he doesn't want me to go on and on. So he's clearly a vital leader for Baltimore City who is committed to the health, safety, and success of the city's youth and community. So please welcome Dr. Jay Perman.
Thank you, Brian, and thank you for not going on. I want to compliment you and Sue and all who've made this a reality and so impactful in our city and really our world. I'm always honored to be in the Senator's presence. I can never tire of telling you how fortunate Maryland and the nation were to have you in Congress. A social worker, somebody who understands what was talked about here. And yes, I'm very prideful because she's one of UMB's own. Proud alumnus, fighting for the vulnerable always. And Sandro, Dean, I haven't had the pleasure of knowing you until this evening. We chatted a little bit beforehand. I didn't know what I was in for. Thank you for inspiring us. As I listen to you, I think about that little cute expression. You've heard it. We always seem to have the emphasis on the wrong syllable. And I think that's what you've taught us, healthcare versus health. I often think of it in my own little world where the centerpiece of, yes, healthcare are hospitals. And as our distinguished epidemiologist knows better than me, 200 years ago, 150 years ago, hospitals, particularly hospitals in Europe, they were the default. They were the alternative. If you were poor and had nobody to take care of you, or if you were dying. That's who went to the hospital. Now the hospital is the shiny engine. And we rave about the facilities we have. I do it. We rave about the instrumentation in those facilities. And as you've seen from the data presented by Dean Galea, what do we get for it? So we have to keep community and home top of mind. And yes, use our vaunted, sophisticated healthcare system as an alternative that, to be sure, is needed at times. Now, I'm no epidemiologist, certainly not a public health expert. I am a pediatrician. And I'll tell you, pediatricians understand something about prevention. In fact, that's the centerpiece of taking care of children. Keep the hospital empty. And I'm happy to say, not because of the economics of it or people who lost jobs, that in our country, massive pediatric inpatient units are becoming smaller and smaller. In community hospitals, you don't even find pediatric units. That's the point. That's what you get when you encourage prevention. I'll tell you a little story that you'll indulge me and let me relate to you. When I was at Hopkins in my early days in Maryland and leading a pediatric gastroenterology program, my subspecialty, I convinced leadership at Hopkins that we needed to have a home care service. That was becoming a big commercial business, providing parenteral intravenous nutrition at home, etc. But I saw home care as something that needed to be part of the delivery system, and certainly for children. And the story I want to tell you that at least illustrates for one patient and one family much of what we heard tonight is the following. We had at Hopkins in those days an 8-year-old child from East Baltimore who had diabetes. And she would get terribly ill again and again. Her diabetes went out of control frequently, and she needed to be admitted to the intensive care unit, where we wise physicians knew exactly how to get her back in control. At great trauma to her, the needles, etc., and at great cost. And then we would send her home. And in several weeks, she was out of control again. Now, physicians always have names for things that they don't understand. And in those days, we used to call it brittle diabetes. In other words, no matter how wise we were in managing the diabetes, somehow she was brittle. She just didn't hold. Until somebody came to me when Hopkins let me set up a home care program and said, Jay, why don't you send a nurse out to the home to give a hand to the mom? And here's what the nurse reported back. She watched the mom drop the insulin each morning in a dark kitchen. That mother could not possibly see the accuracy of what she was drawing up. Why was the kitchen dark? She couldn't afford the electric bill. When that was easily corrected, no more brittle diabetes. No more brittle diabetes. So you don't have to look for stories. There are plenty out there to understand what the real hearts of the matter are. The dean talked about segregation. I'm a university president in a city which is one of the most racially segregated in the nation, and you don't have to look very far to see the health effects of poverty and isolation. When I give talks about our city, I often use maps, and the maps are stark. In the West Baltimore neighborhood of Poppleton, which is essentially where our university is, and we have a community engagement center, which I'll talk about in a moment. In Poppleton, the median household income is under $20,000 a year, and nearly half the population lives below the poverty level. Then you have Roland Park, one of Baltimore's most affluent neighborhoods. And I have nothing against Roland Park. It's on the north end of the city, about 5 miles from Poppleton, and the median household income is $108,000 a year. And the share of households living in poverty is 3.6%. Now, to illustrate your points, life expectancy in these two neighborhoods differs by 16 years. 68 years old in Poppleton, 84 in Roland Park. You don't need statistics to know that that's a significant difference. And everyone in this room can indicate why this is. We see the factors that the dean has illustrated, and what we often call, and what we try to teach at the university, the issues of the social determinants of health. And that's why Dr. Galea's call to arms, if you will, and we start doing something collectively, purposefully, politically, among the upstream, about the upstream factors that have relegated generations of people to sickness. So let me talk about two community endeavors briefly that Dr. Berman kindly pointed out as illustrations, I hope, of the approach that a large institution can take to addressing some of the things that the dean told us about. The community center in Southwest Baltimore that has become so much the cornerstone of our particular engagement efforts. It's where we collaborate with neighbors to cultivate community health and, yes, wealth, jobs, where we try to enrich learning and strengthen neighborhood development. In our Community Engagement Center, we take the tools, the resources, the wisdom we have within the university and take the gown to the town based on what the neighbors want. Job training and placement, free legal advice, fresh food markets, fitness classes, computer labs and workspace. Now, it's not a one-way transaction. This is not, here's what we're doing for you. Believe me, our neighbors helped us build the center. They brought the community to us. They tell us what programming they need, what projects we should undertake together. They advise us on directions and plans, and I am very grateful for the fact that this two-way street gives our students in UMB, many of whom come from the few, from the Roland Parks of the world, an education that they couldn't possibly get anywhere else, and that the community teaches them. When I think about the difference that our engagement efforts are making, frankly, I think this education of our own students is premier among the things that we're accomplishing, this cultural competency that we talk so much about, but that you really can't teach in a classroom. Our neighbors are our teachers, and they remind us of these upstream factors out beyond the walls of the hospital that too often contribute to filling up the hospital. So they shape the professional education of the healthcare delivery system that we're so responsible for. And that's the second and final piece I want to talk to you about, the notion that we have some responsibility to get the appropriate frontline providers into the fight. So one of the things that we're doing is building our future healthcare providers, I hope. 3.5 years ago, we launched the program that Dr. Berman mentioned, the UMB Cure Scholars Program. It's a mentoring program for West Baltimore middle schoolers, starting in the 6th grade. It's designed to excite students in our West Baltimore community to science and start them thinking about careers in healthcare and research. So twice a week, these children, brought by their parents who are invested in this, they come to campus for science experiments and projects, homework help, field trips. They take tours of our laboratories and operating rooms. They interact with our faculty and students. On Saturdays, they're on campus most of the day for intensive tutoring. We've got more than 100 amazing scholars right now, 6th to 9th grade, making a long-term commitment to the program, and 250 mentors, largely our students, who give up a lot of their time to these kids. So why did we do this? We launched this program because we believe that making change in the health space begins with making change in the education space. Now, I know that not every one of these scholars will go into healthcare or research, but that's okay too, because the program is about developing talent and curiosity and dedication so that success is more likely to be achieved no matter what they pursue. But if they do go into healthcare, point I want to make is that there's a snowball effect. Some of you are aware of the recent data that demonstrate that patients of color are more likely to take the advice, and we shouldn't be surprised about this, of providers of color. That's why this work is so important. This was a study by the National Bureau of Economic Research, which showed that black men are more likely to accept preventive treatment when it's recommended by a black physician. Difference of 16 percentage points, black provider versus white provider. When the treatment recommended is for chronic conditions like cholesterol screening, diabetes screening, prostate, they're more likely still to follow the advice. That's an important reason for these pipeline programs, for making our healthcare providers writ large look more like America. Certainly the America of today, definitely the America of tomorrow. But there's one more reason why I think these pipeline programs are indispensable when we talk about making real and sustainable change to policy and practice. These students are already conscious of taking up a cause. They want to invest in the communities they came from, to serve the underserved. They want a platform from which they can influence and advocate. Our scholars, our children's scholars, I know because I work with them, are hardly ignorant of the fact that politics and economics are often at the root of healthcare inequities that put their parents, their neighbors, in their graves younger than anyone else, 68 versus 84. We need to grow a more diverse community of health professionals, researchers, epidemiologists, population health sciences, who have a real vested interest in making change. And I'm happy to have a campus of 7,000 professional students who push us every day to do more, and thousands of neighbors in West Baltimore who push us to do more and who partner with us to do more. So thank you, Dean Galea, my dear friend Senator Mikulski, Dr. Perman, all of you for planting a flag for health equity. Thank you.
Thank you, Jay. Your leadership and your commitment to a community-centered university is a model I hope others will follow across the country, train community-minded leaders of the future. So I'm honored to introduce our next speaker, Senator Barbara Mikulski, someone who probably doesn't need an introduction because I imagine everyone here realizes how much they have benefited from her leadership in our state and our nation. She's a long-term champion for prevention-based healthcare reform, leading transformational efforts to support the well-being of all in Maryland and in the United States. She was raised in the Highlandtown neighborhood of Baltimore. Senator Mikulski attended Catholic schools and was a social worker in the 1960s. After organizing neighborhoods to fight a major highway project, which would have flattened this building here we're gathering in today if it had gone through, she won election to the Baltimore City Council in 1971, where she served for 5 years. In 1976, she ran for Congress and represented Maryland's 3rd District for 10 years. In 1986, she became the first Democratic woman U.S. Senator elected in her own right and served in the Senate for 30 years, becoming the longest-serving woman both in the Senate and in Congress. Throughout her career, Senator Mikulski has worked to pass legislation to protect the most vulnerable members of society and to advance scientific research and democracy around the world. She has also worked tirelessly to champion prevention-based healthcare and integrative health. Working with Senator Tom Harkin, she established the NIH Office of Alternative Medicine in 1992. Then in 1998, she fought to elevate the Office of Alternative Medicine to create the NIH National Center for Complementary and Alternative Medicine, increasing the homeopathic budget of $2 million per year to almost $50 million per year. And then in 2000, established the National Prevention Council and the Prevention and Public Health Fund. And with President Obama and others, she ensured that prevention and health were essential components of Obamacare. In 2015, Senator Mikulski was awarded the Presidential Medal of Freedom by President Obama in recognition of her lifelong dedication to the well-being of society. And on January 3rd, 2017, Senator Mikulski retired from the U.S. Senate. Currently, a Homewood Professor of Public Policy at Johns Hopkins University, she participates in speaking engagements on the topics of leadership, innovation, and women's empowerment across the country. My gratitude is eternal to Senator Mikulski for all of her work to advance integrative health, and her spirit inspires all of us to fight the good fight and to keep the light of hope burning bright. So please welcome Senator Barbara Mikulski.
Steps rather than jumping up on that thing the way you and Sue and all of you guys do. The podium here is built like the podium I found when I came to the Senate. It was built for Tom, Dick, and Harry and not Barr, but I eventually got them to do a size 14 petite just for me. But the podium's going to work, and I just want to say I'm delighted to be here. First of all, to Dr. Galea, I want to really thank you for that cogent and content-rich remarks. You have to know that while I was getting ready to organize myself for this, in my mind I kept calling you Dr. Galileo. But you know, I could see where you've ruffled the feathers of the establishment and come up with some innovations and new designs. But to my dear friends, Dr. Perman and Sue Perman, we want to thank you for really this wonderful evening here at the Institute of Integrative Health, and a salute to you for always promoting here the innovative thinking in terms of healthcare and your whole work in terms of advocating for integrative health and really a new culture as well as new content around healthcare. One of the delights I had in working with the Permans was on a project called the Green Road. Now, we have it, the Green Road was a project that was the Perman innovation working with the foundation. I believe it's Mr. Foote who's here. And the whole idea was to help our veterans who were recovering at Walter Reed Naval Bethesda. Remember, we once had two hospitals, Walter Reed and Naval Bethesda. Naval Bethesda was quite dated, and Walter Reed had become almost dysfunctional in size, shape, and mold, and other things. At this wonderful new facility on the Bethesda campus of Naval Bethesda, it was they work with our military coming back, surviving some of the most horrific and permanent wounds of war. And so did their family come back, surviving the impact of those permanent injuries. And how could we get them on the road to recovery? In addition to the excellent medical care, all the wonderful work that goes into modern contemporary medicine, it was the whole idea about how can we heal body, mind, and spirit. And the Green Road, and maybe Dr. Perman will talk to about it later, is more than a path, but through the grounds of Naval Bethesda, which is beautiful, right across the street in a traffic jam from NIH. was this path, and it's more than a path. It is a path to truly healing the body, mind, and spirit. It's to get the military who are recovering outside and into nature, to have a reflective garden where they can think and meditate, and where they can begin a recovery that is different than only having access to medical care as we define it. And that, I think, goes to the heart of your remarks, Dr. Galea, the difference between health care and medical care. Now, in Congress, when one talks about access to health care, my colleagues, those who are tremendously interested in it, and there are people who are legendary and iconic, like Senator Kennedy, Senator Harkin, on the other side of the aisle, Senator Olympia Snowe, others that we worked on. To them, health care means medical care, and it means access to physicians and a clinical team. That's a good idea, but as you so eloquently and cogently pointed out, it is not access to health care. And that's what I'm going to talk about a bit. But I also want to comment on Dr. Perman. Doctor, first of all, we thank you for being here tonight. We know that the University of Maryland and our friends and neighbors and pals down at the Green Street campus have gone through a traumatic day with the shooting of one of the medical staff. We're sure that you've had tremendous administrative responsibility, and you've got a lot going through it because the trauma occurred not only to the shooting victim and that shooting victim's family, but the family called the Green Street community, those at the medical school, those at the hospital, those who walk that same street. So what we know about trauma, and I think you've talked about it earlier today, it's not only those who experience the permanent assault on them, whether it be a gun or another form of assault, but everybody around them. So we thank you for here, and we want you to know we want to send more than thoughts and prayers, but we'll start with that. So we really appreciate you being here. Well, and that introduction that Dr. Brian gave me, he talked about I'm over at Hopkins, and the answer is right. When I retired from the Senate, I wanted to turn the page, but not write the final chapter. And one of the things that you'll learn when all of you retire is you want to have three things. You want to have financial resources that will support you in retirement, but you also want to have relevance. All of you in this room have dedicated your life to trying to make the world a better place. So you want to keep doing that. And for me, going into teaching was going to be that next step. You know, you had the soccer up there, and it's not only was Miss Solo a great goalie, but they won because they played as a team. But anyway, not to digress, that the fact is that what I wanted to do, you know, a tennis player will be a champion, and they play singles. Then they go to doubles. Then they go to the tennis camp. I'm kind of at the tennis camp stage, and am teaching at Hopkins, and I teach primarily undergraduates who are either in pre-med or in the preliminary program to go on a PhD effort in public health. The only reason they're taking sociology, and I co-teach, I'm with no administrative responsibility. You all can appreciate that. And it was a tip that I got from Senator Snowe in her retirement. But anyway, the only reason they're taking sociology, because they're pretty science saturated. That's what pre-med is, science saturation. Is that now to take the MCATs, they have to have courses in sociology and in psychology, which says there was an innovation, just like your great mentoring, build the pipeline endeavor. What I co-teach is the sociology of health and illness. The proper PhD does the proper PhD program, and I do case examples and provocative discussion. That's me, and that's what I've been pretty good at. But what is the emphasis that Dr. Agri and I do is we emphasize to the pre-med students The millennials, remember this is a different generation. They want to change the world and they want to learn how to do it. We talk about the social determinants to healthcare and to teach them that whoever they treat and whatever field they go in, it could be everything from pathology to neurology to pediatrics, is that everybody they see lives in a social context, and that social context will have a tremendous impact on them. And one of the things that I talk about is something called zip code determinism. Zip code determinism is what happens to you exactly because of where you live, which also determines how you live, which determines how long you live and how well you live. Zip code determinism now in our country, and some of your data indicates that, and I know some of the other data it does, is that your zip code is now determinative of your life expectancy, as was talked about earlier, and your health condition is more determinative of your zip code, is more determinative of that than your genetic code. You can't maybe evade the consequences of genes, like a propensity towards diabetes, which is in our family, but you can delay it because of lifestyle, prevention, and other kinds of things. But if you've got poverty, you've got racism, you've got indifference, you've got a different situation. Speaking of poverty, how many here know what is the minimum wage? Yes. In the United States of America, what is the federal minimum wage? Who said that? My social work friend, Michael Reich, who is the Thurs professor at the University of Maryland School of Social Work, $7.25. And it was done in, I think, 2009. It's been over 10 years. And if you add it all up, it comes out to less than 20,000. So if we're talking about all this, know what the minimum wage is. And for many, the minimum wage is the floor. It is, the ceiling, not the floor. Now, coming back to the class, we teach them practical skills and how to apply them. We even take them through not only this data and this information, but I do simulations with them. And one of the simulations is, I'm the mayor, of course, I make myself the highest, but we have them break into teams to be the health commissioner, the police commissioner, the school commissioner, and the head of public works. And I compare two neighborhoods in Baltimore. The neighborhood from Freddie Gray came from. For those of you who are from Baltimore and maybe visiting, Freddie Gray is the young man who died in a police van almost 3 years ago, and that triggered the riots that occurred in Baltimore. And he was from a neighborhood called Sandtown, Winchester. But in that class, we talk about how Freddie Gray died many times before he got into that police van. He died many, many times, and nobody came to help him. One of which was the cognitive impairment because of lead paint in our housing, which left him severely challenged all of his life and down a different path. And then we compare that Freddie Gray's neighborhood with Canton, a young people's gentry neighborhood just up the street from where we are. Well, they actually love it because I say, I'm the mayor, I'm going to make a difference. Here's all the data from social disparities from our health commissioner. Give me 4 recommendations next week, and so on. First of all, it forces them to work in teams. This is new. Second, to actually think of something concrete that they would do and what I can do as a mayor. Well, most of all, they're really good in public health. They come back to lead paint. Then I raised lead paint in the water coolers at school. Had they tested for that? Anyway, you get the picture. The point is, it opens up their mind to what all it is. And if they were treating one of the children that had come into the ER, the way you spoke about the childhood diabetic, they learn a lot. So we're teaching the next generation about what they need to be aware of in clinical practice. And then I encourage them to become involved in advocacy like I'm encouraging you tonight. I'm here tonight to say we've got to get off of the benches and we've got to get into the trenches. Now, Michael knew the minimum wage. You can all say, did I know the minimum wage? Okay. Now, I'm going to ask a question. You don't have to raise your hand. How many here are registered to vote? How many in the last 12 months have been in an elected official's office advocating for something? Well, you're paid the big bucks to do that. And have you even thought about it? This isn't chastising or whatever, but we have to get off of the benches and into the trenches. You see, you're actually needed more now than ever. Many who are involved in healthcare know that you're facing so many efforts that leave you dismayed and feeling pretty daunted. And the American people are feeling that. It was the central issue in the last election, but it was access to health insurance, which to them is access to a doctor. It was not about health care, because if you get into health care, you're going to talk about globalization. You're going to talk about the race to the bottom and the bottom winning. You're going to talk about death by despair in communities like Kentucky and even up in our own Western Maryland. What are we talking about? Also, but they were talking, the voter was talking about if they could only see a doctor and not have to worry about a pre-existing condition. And you know what? It is threshold. We are not minimizing that. We are not knocking that. In the United States of America, this should not be an issue. But it is an issue, and that battle needs to be fought. But it is not the only battle that needs to be fought. We need to look at these other battles. First of all, we've got the issue of the opioid epidemic. There is the corrosive and permanent effect of poverty. You spoke today about trauma, not both the gun violence trauma, but there's trauma of racism. There is the trauma of sexual assault, and we could go on about these awful, horrific traumas. Now, it's hard to believe that it was 10 years ago, just in late January, that Barack Obama took his oath of office. 10 years ago, change was in the air. Optimism was running high. I remember that inauguration so well. President Obama gave his inaugural address. The Senate hosts a lunch every time a president is inaugurated and invites the president and the First Lady and members of their family. On their way for Barack Obama to come to have lunch with us, Teddy Kennedy on the way has a seizure, and he never comes back. He never comes back. He makes maybe a cameo appearance. And yet we were charged with moving on healthcare reform, and we did. Over in the House, and our hometown girl, Nancy Pelosi, helped make sure the House organized itself. She was the speaker for that brief window. I was in the Senate. I was on the committee. We worked on it, and we began to work. But we wanted to do not only access to medical treatment, we also wanted to change what health care would be. Leaders like Senator Harkin, people like myself, others who had worked over the years with people like Dr. Brian Berman, Dr. Wayne Jonas, Sister Charlotte Kerr, who's here now, who's also an advocate of integrative health, and also knowing that healthcare is a form of social justice that we need to be an advocate of, and we all worked on it. We could go into what we did in integrative health. We might want to cover that in the questions and answers. But we knew we had a system that reimbursed for sick care. We knew that we didn't focus on the right things. And we started that 10 years ago. We had a movement. We had momentum, knowing that access to medical treatment should be threshold. But as we worked on that, there were the forces that gathered against us. That became the Tea Party. And so you take a state like Kentucky that had a fantastic governor that set up a tremendous opportunity for the exchange. They had one of the highest rates of people signing up for health care. They also had the emerging high rate of this death by despair, suicide or by opioids, or the consequences of neglected chronic conditions that had been left untreated, and they died. But the despair was through your own hand. You were shortening your life. They were burning Obama in effigy in Kentucky, even while they were signing up for Obamacare. Well, we got to be aware of this. So Obamacare and the ones who were the Tea Party then came to the House. They had a big majority. That's the Freedom Caucus. When you hear about the Freedom Caucus, that was the Tea Party that has morphed into this. So that's just my background. So we were working on all this. We thought we had momentum. But when that Tea Party came in, we were derailed. And there was a singular opposition to everything that President Obama wanted to do. This is not the night to go into Obama and 8 years with Obama, though the man that you think you know is the man that is so. And one of the most poignant meetings I had with the president is when he came to Baltimore. We had a Democratic retreat, and we took him up to Joe Jones's Urban Families. And in a round table, he met with families. And if you saw him interact with people who had been there, a young man who talked about how coming to that center turned his life around, and he learned to be a father because he never had a father and what it meant. And the president says, you know, I didn't have a father either. I know what having good men to help me learn means. And a woman who said, well, you know, Mr. President, a couple of years ago I was in jail, and he said, what for? And she said, murder. And the whole Secret Service immediately took a deep breath. And I'm sitting next to O'Malley, and he said, oh, God, where are we going here? And she talked about domestic violence and defending herself. Anyway, if you would have seen the president interact, I'm not here to say hoorah for Barack Obama, but we had an effort. We had empathy. We were making gains. But now that's begun to fade. And the only way we're going to change that is if we get off of the benches and into the trenches. Now, I'm here tonight to go over, we could go over and validate what you've said, Dr. Galea, but then what? So my feeling is, first of all, we must go to the young people. I love what you're doing at the University of Maryland. That whole mentorship, exposing them to what you're exposing them to, they're learning it. What we're trying to do in the sociology courses around social determinants. But you know what the kids say? Well, I've been active. I've been to the protest. You know, Senator, I went to the march. I think I saw you there. I got the T-shirt. When are we going to end poverty? How are we going to get that gun control? You were there at the campus walkout when we went in solidarity with the kids from Parkland. What do we do? And it's how do you go from outcry, which I'm a supporter of, I got into politics as a protester, to outcome. And that's what we need to teach, but it also means to organize. And I'm here today to say you need to get active. This is what we tell the students. Get active, I'll come back to the young, through your professional organizations. What the students and faculty sometimes say to me is, first of all, the students say, you know, my parents don't want me to do this. They're afraid that I won't be able to get into graduate school. They're afraid I'm going to be on some facial recognition for being at the protest. And this is going to hurt. My father and mother are working so hard. They're running a carry-out in, Hyattsville or working here. We don't want to do it. The other, sometimes you hear from the faculty, I might not get my grant. We're supposed to be objective. We're supposed to be value-free. We can't be partisan. I'm not saying pick a side in a political campaign. I'm saying pick a side in the cause of social justice. You have to make that distinction. I'm not here to advocate your participation in partisan politics. That's your choice as citizens, if you are citizens. And hopefully you have a path to become a citizen. But what I am saying is you must get civically engaged. One of the best ways is through your professional association. Some of the best weeks we had was when the American Public Health Association would come to the Hill, when the American nurses would come and they would come, when the kids themselves would come, but they came not only because of the crushing student debt and they wore their white lab coats, they came because they wanted to help people and they knew it had to be different. You have to be involved like that too, through your professional association. Then if you're associated with academia, please, you must introduce those courses. And then third, really to be involved with the students themselves. I love being in the classroom, but one of the things I like is what occurs when they have come during office hours and you get a chance to talk to them, encourage them, give them a tip. Sometimes it's for survival, when you're in your third year, etc. This is really, really important. And then, if that's not your thing, one of the things I want you to put on your radar is the census. Now, Barbara, what the hell are you talking about the census for? If you want to close disparities in Baltimore, you want Baltimore to have the best census a city could have and that there be no hidden figures. Either the immigrants who are afraid of a citizenship question and being discouraged, the person out on parole, any number. The census determines, and when it looks at federal funds, 80% of federal funds coming to this city and to this state are determined by a formula. And that ranges from Medicaid, school lunch programs, Section 8, to mass transit, to, of course, political reapportionment. We need a real census. Now, Mayor Pugh's working, and we need to have academics who are also involved with community outreach involved. And if Mayor Pugh and her Community Counts Committee, the mayor is very serious about this, then volunteer. And that goes to saying, what can we do? Because what I like about the School of Public Health, they're interacting with people all the time. Your fantastic outreach that you do in West Baltimore, really, the work that nursing, pharmacy, medicine, and of course social work is doing is really fantastic over there. You should feel very proud of that. But we need to make sure we get an accurate count. That's not partisan. It won't affect whether you get your grant or you're on a facial recognition because you're helping somebody fill out a form and so on. Last, but not at all least, let's look for allies. And I look for allies in unfamiliar places. And that is go to business. Business needs a workforce. And business needs to also control and contain their healthcare cost. Unless we can go and get allies that will support our advocacy for social justice, we're going to have a hard time making it. And I believe that there are businesses with, one, a social conscience that will want to be of help, and those that just want the sheer economics of it. So when we look at it, those are my recommendations. I could go on about them. but it really is the advocacy and getting off the benches and trenches. So, Michael, this is what I've done when I've talked to social workers. These are my principles for advocacy. First of all, we have to be value-driven. And the value is that all people are worthy and entitled to respect. Now, all of the systems and policies must serve the client or the patient, not the client or the patient serve the system. We must be, as professionals, advocates for the people we serve, whether we're a clinician, administrator, or a policymaker. We have to be a voice for the voiceless, and not to seek power, but to seek to empower the people we serve. And no matter where we practice, who we are, what we do, we need to do it. And people say, I've got tweet fatigue, I can't take anymore. Be best at what you're best at, be best at what you're needed for. We need your ideas, we need your idealism, but please stand up, speak up, and show up. Thank you very much. Was this watch here for me? For me, it's almost like a sundial. Should we sit down?
Would you please? Could I ask Sandro, Jay, if just to come up? I think we have time for a few questions.
I'll get in the middle of these guys.
I was hoping to swap it. It was a little nicer one. Well, thank you, Senator. You continue to inspire us all, and that was a very, very clear message. So we have a few minutes. I think there's some dessert out there as well, but we have a few minutes for questions and conversations with all three of our speakers. So I'll open up the floor, but maybe I'll take the moderator's prerogative and ask the first question while people are thinking. We have microphones there. Just raise your hands. So I guess it's for all three of you, and that really is, how do we create a national conversation about health? I mean, how do we actually do it?
Go ahead.
Well,
You're the instigator.
I'm often asked the question. The answer is, I think everybody who believes it's the right thing to do has a responsibility to do it within their space and their sector. I feel like I am doing what I think I should be doing, given my platform, and I have tried to be to push that platform as much as possible. I think the senator and the president are doing what they should be doing in their platforms, and it feels to me a conversation is a quilt of different voices. So I would urge a collective raising of voice towards that quilt.
I think there's already a conversation going on, and it's certainly starting with the presidential campaigns. So one will be health insurance. And that's the debate going on, and it's already underway, on should we have Medicare for all. Just to clarify Medicare for all, because there's going to be a lot of different ideas on what Medicare for all meant. But during the when we were working on Obamacare, we had something called the public option. The public option was in our original legislation to move towards the floor. A public option, remember the exchange, was that you could buy into Medicare. It was primarily focused on people over 55, close to 58 or maybe 60, who were within reach of Medicare, but because they had lost their job and any number of things. Remember, we had just lived through the 2008 economic crash, and the public option was to be a bridge to get you also when you could be eligible for Medicare, but it was meant to be an option. It was killed because we did not have the support of Joe Lieberman of Connecticut, and we were one vote short of it. And really, it was because the insurance companies felt threatened by it. And I'm not knocking Joe here. This is not, I'm a great admirer of Senator Lieberman at many many different issues. But the insurance companies were afraid of a public option that everybody would run to it. Well, not everybody was going to run to it because 80% of the American people get their health insurance through their employer. That's why bonding with employers is one of the ways to go. So anyway, so the debate is starting on health insurance. The debate on raising the minimum wage is already part of that. And how we're going to participate, because small business says, you've heard the argument, it will raise prices. You know, Jimmy's Diner up the street. But the fact is that one of the reasons that people need public subsidies is because they're so poor. So we're paying for it, one way or the other. And the question is, shouldn't we rather be paying for it through wages that lift families up? And also, it's over a decade. I think we ought to have a minimum wage. We ought to raise it. I'm not saying what amount, and we should index it.
Very quickly, all of us on the platform here, and many of you, have the privilege of working with students. You heard Senator Mikulski talk about her students. I mentioned my students in the community. If I've learned anything in my years as an educator and administrator, follow the students, listen to the students. I don't tell them to go into the community. They come and say to me, help us to make a change. So we need to enable our students, guide them a little bit to be sure, but listen to the students.
But Doctor, while we're listening to the students, it's how we also show, and I think Dr. Galea has mentioned this, that what they see, you have to draw the public policy links. So we have a great program at Hopkins where the kids volunteer for Habitat for Humanity, particularly the engineering students, for example. And I love Habitat for Humanity. What a difference it's made in the lives of people. But how can we make housing more affordable also has to be part of that. I could go on about every feeding program or whatever. And anyway, so it's why do we need the program? Not in a negative sense, but what is the deficiency in society that shows what the need for this program is? And one of which is wages. You know, most poor, this whole thing about, pardon me if I get off on this, we got to make sure those Medicaid recipients work. Yeah, goddamn, they better work. They can't have any laggards. Pardon the language, but that's what I hear. Well, the fact is, if you look at Medicaid, 80% of the beneficiaries are children. 80% of the money goes to the fact that people are in long-term care because they have Alzheimer's, because they have Parkinson's, because they're debilitated, and the family has exhausted a good bit of their life savings. Who are we going to put to work? Let's bring back those sweatshops for those 9-year-olds. I mean, I could not be sarcastic or snarky here, but we have to talk about these things and stand up for the reality of it. And the discussion is going on right now.
Okay, thank you. George?
Yeah, three wonderful presentations here. I want to bring up a request for you to comment on what we can do about the media. It seems that the media has become so segmented and such a powerful source of misinformation, including about health, that it is driving much of the narrative rather than reporting the narrative. And I wonder, in the three of your experiences, whether there are any strategies you can imagine to try and bend that curve a bit.
Well, first of all, the decline in print journalism is really sad. You might remember when Baltimore had 2 newspapers, now we have one that's doing its best to hang on. The thing about print journalism, particularly where there are authentic newspapers, they had sources, they followed stories, reporters had beats. So when you talked about Medicaid, from DeMonte Driver, the little boy who died because he couldn't see a dentist, and an $80 procedure, all the way up. We don't have that anymore. And what we have is the 24-hour news cycle and the battle for ratings, and the battle rewards the sensational and those who say the most outrageous. So I think, but you can use your social media platforms. It's really, now I think it's really knowing social media, and it's using the new approaches like podcast, doing your own production, streaming. You know, I was a big supporter, as you can imagine, of the Democrat year for the women and trying to get the blue wave to be as big as it could. I was so impressed about the upstart candidates' use of YouTube. And we have to look at new ways of communicating. And media, in some ways, has been democratized if we then know how to use it. And it goes to what you're saying, Dr. Perman, that those kids will show you how to do it and get that out. So I think social media and the new media is the way to go.
Grace?
Senator Barbara Mikulski, I was one of your students at Sociology of Health and Illness, and I just want to attest to
Where were you one of my students?
Sociology of Health and Illness at Hopkins.
Oh, great.
Yeah, so I just want to attest
I've
to.
got the light glare. I can't see you. Oh, I remember.
You remember me?
Weren't you the guy? Yeah, when I looked out, weren't you in the left side of the room?
Yeah, I was on that side of him. Yeah.
Yeah.
So I just wanted to
He was
attest.
brilliant. He was absolutely brilliant. Oh, my God. I'm glad to see you. Have you won the Nobel Prize yet?
So I just wanted to attest to all she said about that class. We also did that practice with the mayor, and it showed me a lot about just social determinants of health. And I just wanted to attest to that. But my main question is for Dr. Galea, because at Hopkins in public health, every class that starts talks about how the U.S. spends so much on its healthcare expenditures, but we have the worst health. And I wanted to know, because the presentation was amazing, more interesting than any class I've taken thus far at Hopkins. And
That's all right, Senator.
I just, so the question is,
Oh, go on. Oh, go on.
I wanted to know, like, what pushed you to almost go outside the box and actually, like, to go into because all those things are not what you learn in class. You kind of put a bunch of things that are taught and that are true, but put them together. So I was wondering, like, what pushed you to put all those outside the box sources into this coherent theory?
Well, it was very. As I said, this presentation is a book that's coming out in May, and you know I've done several books. I mean, this book is a bit of an experiment for me. It stretches what I've done before, but every single time I write a book, my goal is to look forward to somebody doing a better book than this one. So so I actually, I'm really write this book, and I say in it that I intend some of these things to be provocative, and I'm looking forward to somebody doing it one better. So I really think that one of the great privileges of being within the academic world and the world of ideas is that I paid to generate ideas, hoping that somebody else will come up with an even better idea. So I'm really, insofar as I'm pushing that boundary, that's great, and I'm doing my job, and I look forward to then you writing something even better.
So maybe last question to Grace.
This is a question for Senator Mikulski, and I just wanted to know that, or I just wanted to ask, like, as a young woman, how can I help empower the other young women around me to follow role models like you and become more a part of, like, public health and, like, actually bettering our future?
Well, first of all, I believe the power's in the group. Michael Reich and I are community organizers. It is in the power of the group, but it takes one person finding another person, and those two people finding two people. And then all of a sudden, you've got 8 or 10 people. And that's either being active in an NGO or really being active in a political campaign. We're going to have a presidential campaign coming up, right? It's actually started right now. Going on. But the other is, I think, really following this census right now. Are you in public health or pre-med or? You're
High school. She's in high school.
Well, you seem far more ahead of your time. We'll take you. You can- and first draft, Hopkins. Anyway.
Wait a minute.
Wait a minute.
Thought the senator was my friend.
Don't forget, this is Switzerland.
But I think also right now, getting involved in a nonprofit or following what's going on in Annapolis. See, there are several different levels of legislation, the city council, and of course what's going on in the Maryland General Assembly. And they're going to have several issues that you might want to be involved with, from everything from minimum wage to health care to things like the rape kit backlog. And I know that's a tremendous interest to young women, where people have been sexually assaulted, the proper forensics have been done, and the rape kit's language without it. Delegate Shelley Heddleman is a real advocate of that. So to look at some of the issues going on and follow it through and actually lobby for it. Okay? And I'll talk to you a little bit afterward.
Okay.
And I have an application here.
All right, so this one is the last question.
So a lot of the discussion that we've been going with is what do we do next after all the work that you guys have done? And so if you guys had all the expertise, all the experience, all the knowledge that you have now, but you were 20, 21, 22 years old, what's the big thing that you would do now going forward?
Wow.
Well, if I were still in the Senate, I would be the ranking member on Appropriations Committee. That's now been done by Senator Patrick Leahy. Over in the House, the chair of the Appropriations is Congresswoman Nita Lilly. I would right this minute for the next several weeks now is to make sure there's no federal government shutdown. And by that, I mean, it is outrageous that our government comes to halt, that we wonder, are the Section 8 money going to be coming to Mayor Pugh and her efforts? Whereas this, the fact that NIH, though parts of it were exempted, we're running in to see if their own research, as you know, as scientists, years and years could be literally die in an untended petri dish. I mean, I'm exaggerating. So right now, the United States of America needs to show that it can govern itself, and that should be functioning, whether it's our air traffic control, our FDA, for food safety and food inspectors. I mean, right now, though I have 3 chronic conditions, I would be more at risk from a foodborne illness than mortality by my chronic condition. So I'd be fighting the shutdown. Does that surprise you? No, in other words, had you thought about that? This is not a quiz. Because, see, this is not to put you on the spot. We're not looking at how our government's working. And we have to make sure the government is working, and it's working in the interest of the people here. So that's really part of it, and that's not partisan. So, I don't know, what would you do?
Well, I think back to my medical education. I know about my colleague physicians here. If I could do it over again, I'd flip-flop it. I can learn about molecules in a lot of different ways, including using all of the means we have to look things up. I would have much rather learned about people I didn't understand and know. And I would have flip-flopped the curriculum. Much less in the classroom, much more out in the neighborhood.
You would have made a great social worker.
This is my call.
No, you are. No, you are.
Our
It is.
keynote speaker, Sandro, do you want to?
Yeah,
Last word.
I think I would choose within the realm of something that's going to pay you to make the world a better place. And because you need to get paid unless you're independently wealthy. But there's a broad swath of things you can choose within that. Choose what appeals to you more. If it's medicine, it's public health, if it's writing, doesn't matter. if it's advocacy, if it's electoral politics, it doesn't really matter. Choose that one. Choose it and get really good at it and just do it. Because I actually think that ultimately it takes people from all multiple sectors to make the world a better place. Choose what it is that works for you. It has to be an intersection of what the world will pay you for, what is going to be good for the world, what you're good at, and what you like to do. At the intersection of those four, you can do something for a long time. 21, you're ready to decide. Choose and do it. That's it.
You know, the Marines have a saying. The Marine Corps has a saying, and I've said it all the time. Be best at what you're best at. This is amplifying you, Doctor. Best at what you're best at, and be best at what you're needed for. And you do those two things, you'll be okay. It'll be bumpy. Bruises heal.
So I want to thank all of you, Sandro, Senator Mikulski, Jay, for an amazing discussion. I want to thank everybody here for being here this evening and joining in. And I think it's all a catalyst for us to really do what matters going forward. So we'll give a big hand to our
Oh, wow.